Okay, so thank you so much for making me part of this IC, and I would like to talk about ROP surgery, when to operate and when not to operate. So basically 40% of cases which are referred to surgery for me look like this, and the next 40% look like this. So already this is already too late for what is happening and the cases where we are referring. Therefore this talk becomes very apt when to refer for surgery. So you want to operate these cases when the TRD is low and early, and not when the TRD looks like this, it's late. So basically if you have a low TRD, which is less peripheral TRD, macula is spared, you have less neovascularization, then you would have a higher chance of doing a lens sparing surgery with easy instrument access and a good traction relief with something like cases which look like the photos above. So surgical outcomes in stage 4 ROP are very good, and if you operate them in time, then you know the whole thing just disappears and it looks very nice at the end of the case. So it's very important to have a close lookout of the cases which are going to progress. So let's see this case on the left side. You can see a small hemorrhage is happening and a small area of traction is developing on the top left side. In the next 2 weeks, this is what it turns out to be. So you have to have a very close eye of every small traction which continues to progress. And unfortunately, this child got sick and he was advised surgery, but then this is what he went on to be later. So this is going to progress very fast. Even a small patch can continue to progress very rapidly if it's not treated in time, and therefore you need to go in early in these guys. When cases come like this, it's already too late. When you can see the TRD behind the lens, it's already getting too late to operate these eyes. Simultaneous bilateral surgery is something which a lot of people have started doing, and this is something which is very important because this is a bilateral disease. ROP progresses very fast, and usually stage 4 comes parallel in both the eyes, and if you operate both of them in time, then both of the eyes can be fixed simultaneously. Obviously it involves a single exposure to high risk GA. That's another advantage. And obviously to treat both the eyes as 2 separate surgeries, you have to change the gloves, fluids, instruments, etc. And consent is very important. So just to give you an idea of the basic principles here, so basically you want to deal with the centripetal traction, you want to deal with the vertical traction which is pulling the TRD, and you deal with the circumferential traction so that TRD can fall back. So same principle being shown here in this case, where you can see that the traction is being relieved centripetally and the fold falls back. Here the vertical traction is being relieved so that the TRD can fall back. And here you see the bleeders are happening, so you can just diathermize them and they will no longer trouble you any further. And this is how it looks like at the end when all the 3 types of traction have been relieved, and eventually this will fall back. Posterior TRDs are a different game altogether because in these cases the macula might or might not be vascularized, and you are dealing with something very close to the disc and the macular area. So in this case a slightly different strategy might have to be adopted. So here again you see that traction is being relieved over the TRD. You can see how yellow the vitreous looks like, and all this yellow thing will disappear once you see in the later stage. Here LIO has been done just prior to surgery. We like to do it just prior to surgery because sometimes the instrument might not just reach the periphery intraoperatively. Here you can see that the posterior vitreous detachment is being done, and you see now the yellow vitreous is gone, everything is looking pink in this eye. And this is how it looks like at the end of surgery. Again, this is again a late presentation. So you would want to prefer cases which are much earlier than what it looks like at present, although the outcome did turn out well in this case. This is another case which came to us. Again, you see, idea is to relieve the macula in this. It's already laser extensive TRD both the sides, and once all this PVD is released, here see that is the fovea which is being pulled there, and the idea is to relieve the traction over the macula. And you see now the traction is relieved and this macula is going to fall back. The traction over both the arcades. So one arcade could not be released, but the other arcade we are trying to remove is going to release, and it was released. And this is how it looks like. One arcade could not be released, the other arcade was released, and the macula has been released. And this is what it looks like post-operatively after a few weeks. You can see the maculas look absolutely normal in this eye, and the traction has been relieved. Sometimes the traction is stuck posteriorly, so whenever hemorrhage is there, don't wait. You go in early because the TRD could be happening beneath the hemorrhage. So once you do that, you can remove the hemorrhage and see where the fold is happening, and again that can be relieved very nicely. We do like to combine anti-VEGF in some of these surgical cases. For example, look at this case where you can see that's already lasered and stage 4 TRDs continue to progress, and there's extensive neovascularization. The important thing is extensive neovascularization is there in this case, and it continues to progress. So what can you do? If you do surgery alone, then it might have its own set of problems. So let's see what we did in this case. So again, 25G lens sparing vitrectomy is being done in this case, and you can see that again the yellow vitreous is there. And so once you do the vitrectomy here and do the traction over the entire TRD, this TRD will fall back over time. And then I'm going to do the posterior PVD here, and once that is done, so that blood, even if it has post-op bleeding, doesn't bleed there. Here I've just pinched the cannula to show you how extensive the neovascularization is there. and here air comes in the end, and after that half dose injection ranibizumab is injected into the vitreous cavity through the green tape cannula, which you can see coming here now. So this is how it looks like. So this kind of clean outcome doesn't happen by surgery alone, as surgery could lead to further progression in this eye, or it could lead to a bleed post-op. If you give injection alone, it can lead to a crunch. And if you do combine both these things together, then you can have a very clean kind of outcome. But it should be done in selected cases only, where extensive neovascularization with progressive TRD is noted. Sometimes you can have poor instrument access. If you have a TRD here, it's very difficult to get instruments inside and approach the retina if you want to do especially a lens sparing surgery. So you just like to mark it with these blue dots with GV paint, and then so if the TRD is, let's say, on the temporal side here, then I usually like to go nasally, and then I will rotate this, and so that I have a superior access here. Or you can choose the approach which Dr. Dogra likes to do, sit nasally and then go through the ports in the nasal way, and then you can approach the temporal TRD in a more effective manner. Sometimes if it's 360 TRD, then you can't go through either way, and then you have to go through a clear corneal approach, otherwise you can end up in the subretinal space. So this is showing you a case where I'm just intending to show you that there's a 360 TRD. So clear corneal approach, lensectomy is done. This is more like a stage 5 approach, as we like to use. So this is posterior capsule is removed, and then the dense vitreous membranes are there. Again, you see a lot of yellow vitreous is there. You remove all that, and there's 360 TRD, so you shouldn't go too much in the periphery. And you can see the retina is attached, and the traction is although is there in the periphery, which cannot be removed, but that's how it stays, and this is how it can be done in sutureless manner. So repeat surgery sometimes is needed because if you operate this eye like this, and this is what it ends up with. So if you should give it a try, because if you leave it like this, then nothing much benefit is gained in this. So sometimes if you operate these eyes, a good outcome can be obtained, and repeat surgery can be tried in many of these cases, especially if a bleed has happened, because TRD can continue to bleed the bleed, and it's important to do a vitrectomy after that. So this case shows that a post-vitrectomy RD happened, and there's a break at the area where the traction was there. Now a retinectomy is done over the ridge in this vitrectomized eye already, so that a mini GRT is being created, so that the retina can fall back, and so the ridge is basically being cut, and this is more of an advanced maneuver. And now I'm doing laser there, and the retina is flat here, and then oil will go in the end, and then later we will remove the oil, and the retina can hold on to this. This is a very unfortunate condition, stage 5 ROP, and you'll be surprised to know around 30% of cases which reach our center come to us like this. This was a child of a pediatrician. This is what it looks like, and this is a huge amount of blindness happening in our country, and because people are not screening these babies and they're going blind. So the recent IC278 classification, in which Dr. Anand also a part of it, they divided into stage 5 into 3 parts. Stage 5A. These are photos from the ICROP paper only, and you see this is how it looks like in stage 5. So can we make this outcome better? So many of these cases I do not operate, because if I cannot make them better than this, what it already is, I might want to leave them. If I can make them better, then I try to go in. Otherwise, you might leave them alone as it is. It's stable. These are the cases most commonly operated here, because the cornea is clear, the AC is formed well, and there are no anti-segment changes. And if you really want to attempt, this is a good situation to attempt these cases, and you might benefit in these cases. Stage 5C can have corneal problems, can have pupillary problems, can have flat AC, can have dense retrolental membranes. They might be difficult to operate. A lot of people give a try in that. Some people like to do 2-stage surgeries, but if you cannot make it out better, then you might stick to 5B cases, where you might have a better outcome. Ultrasound is useful in many of these cases, and in some of these cases you might find that the more open funnel configurations obviously turn out to be better, and so we classified into various different patterns, but some patterns turn out to be useful in these eyes. Just to show you how we like to do it, so this is a clear corneal approach. These are instruments going through the clear cornea, because it allows for a safer access. So now lensectomy is being done, and this is the retrolental membrane, as you can see. So an opening is made in the retrolental membrane, so that you can access the posterior part of the retina, and once you have this opening in place, then you can continue to dissect it further and continue to operate deeper into the retina. And so some people like to go through the central approach. If you go to peripheral trough, you can go through the peripheral approach as well, and then come centrally. Depends on the situation. And here you can see the retina is open, and the disc and macula were attached in this case, and this is how you come out in the end. So you see various type of outcomes can happen in stage 5 surgery, but what I would like to show you here is these cases are not all blind now. What you had earlier was a dense opacities in the posterior synechiae, retrolental membranes, closed funnels, and these are all, although you can't say they'll be 6'6", but they'll have hand movement. You can say they'll have finger counting. They might have 260, 360, and this empowers the child and gives them some kind of navigable vision. These children are able to move about. It also empowers the family in a big way. So surgery should be attempted in these eyes. Although the outcomes may not be good, but it can have some decent outcomes if attempted in the right way. So in conclusion, these babies are fighters, and they have survived for a lot in the NICU. And if you can operate early and give them good outcomes, then I think it will be a true fight for these preterm babies. Thank you so much.
Thank you, Dr. Parijat. That was very well elucidated.